we talked about the healing process of the wound, the important part that we have to talk about is about assessment. And I'm not going to talk specifically wound assessment, because one of the very important things that we have to understand is we do not just assess the wound. Going to that proverbial understanding that we need to do the assessment of the whole patient rather than the whole in the patient. What are the principles that we already alluded to is that first of all, we need to understand what we are looking at. What is the etiology of the wound? What are the causes of the wound? And we will deep dive into that in the next session as well. What are those factors that are delaying healing? Modifiable, non-modifiable. What are the goals that we're gonna do? Do we sit down with the patient, listen to the patient, understanding what their preferences are? Definitely we need to do that. Because one of the things that has changed a lot, also looking and talking about evidence-based practice that we said before, is that we have moved away from concordance and compliance, especially compliance because we don't dictate to the patient. We moved to empowerment. Getting that patients with us as partners in their own care. And like anything else, once we have implemented the care, we look at the evaluation of what has happened. Have we reached our goals or not? So what we need to do here is start thinking about the principles of assessment. What do we need to do? First of all, look at ourselves and understanding, do we have enough knowledge and ability to understand the anatomy and physiology and pathophysiology, understanding that we need to analyze and interpret what is happening in the wound. And hopefully this is why many of you are here today, because we have a hunger to increase our knowledge. But remember, these are just basics of it, and we need to learn a lot more to be confident enough to make decisions which can change the patient's life. A wise man said once that if we don't plan, we are planning for disaster. The same happens with wounds. If we start putting on dressings without assessment of the patients, we have a problem where wounds don't heal, where wounds become a lot worse. In the activity that is suggested in your activity book, there is a reference to a video by the NHS to this fictitious patient who is called Betty, where they look at, because people did not have enough knowledge, because an assessment wasn't done, how things went badly, and then comparing to how things can go differently if we do a whole assessment. So we are going to go again and talk about that inquisitive mind that we talked about, evidence-based practice, but this is a different type of inquisitive mind. It is more of an investigator mind, where we start doing a whole assessment based on a holistic outlook. Looking at the patient, what is the environment of the patient? What is his concern? Does he have support, etc.? Looking at the full medical and nursing history, creating a full picture that helps us to put the pieces of puzzle together to make sure that what we are doing is in accordance to what we have. Because as we'll see later on in the different modules, management of different wounds is very different from one to the other. Part of your holistic assessment is sitting down with the patient. First of all, creating that therapeutic partnership with the patient. Making them understand that we care for them, we understand their worries, and also get from them what problems might be that would prevent their wound from healing. Where are they living? Do they have support? Sometimes even looking at the financials. Are they distressed? What is their mental ability? But also now we start going closer to the wound and start assessing the wound itself. But before we assess the wound, we need to assess the peri-wound area. Things that might affect the peri-wound is, for example, maceration. where we have wounds which are highly exuding, where if those cells come in contact for a long time with these fluids, you will get that maceration, which will obviously create a bigger wound for you. Excoriation, which is a superficial thickness of skin loss. We have also epibole, which are these rolled edges at the circumference of the wound that if we don't remove, epithelialization will not occur. Something very common in dorsal ulcers of diabetes. Callus formation. Removing that hyperkeratotic skin is really important because, first of all, we remove pressure from the ulcer and allow the ulcer to heal. We can talk also about induration and erythema, which are both associated with wound infections. So before you start analyzing the wound, start analyzing the peri-wound area. Another important thing that we talk about a lot when it comes to wound assessment is wound measurement. So wound measurement can be either two-dimensional or three-dimensional. What do we mean? So if we take length times breadth by means of using a paper ruler, that means that it is a two-dimensional. If we want volume, we can use something like a cotton tip applicator that we put in the deepest location of the wound, and then we have the volume. However, for me that's a bit of a problem, because if I remember many years ago when I was sitting down in my mathematics lesson, length times breadth times height is a cube, length times breadth is a square. And I have never seen a wound which is a square or a cube or an oblong. So one of the things that we can do, which doesn't cost a lot of money, and get a better idea of the size of the wound, is by using tracings. So these tracings, you have a part which can be put on the wound, which is sterile. Then we have an acetate at the top. We do the perimeter of the wound. We detach the top part. We can put that in the patient's history, and the other part that was in contact with the wound gets thrown away. But we are living in a digital society now, and we know that taking pictures is probably one of the best ways how to do that. Nowadays, fortunately enough, we have very good apps that are on our phone that will help us not just in wound measurement, but also help us in communication and also help us in documentation. For example, if you are like me and you open your photo gallery on your phone, you can have a couple of pictures of my grandkids and you have a couple of pictures of an exuding sloughy wound, which is not very nice. With these type of apps, you can put these pictures in one place. They will categorize them according to your patients, but more importantly, many of these type of applications, for example, talking about an application called Helico, that you can take a picture of the wound and it will give you the exact measurement. Another thing that we take pictures for is when we are publishing. When you are going to take a picture, there are a few rules about making it simply. Make sure that there is no clutter behind the wound. Focus on the wound. Try it to take it at the same angle and at the same light with the same camera every time. And if possible, use an L ruler next to the wound, so when you look at the picture, you have an idea of what it is. But again, if you use these type of applications, it makes it a lot easier. One bit of confusion and difficulty we find is how do we measure tunneling and undermining? So tunneling and undermining can be measured by means of using that same type of cotton tip applicator, and when we are talking about where the wound is, we use the clock face. So the patient's head will be 12 o'clock and the feet will be 6 o'clock. So if we have a wound, for example, at this area of the patient and tunneling is over on this side of the area, we can say probably it is about 4 o'clock. So understanding that with the clock face we can communicate with each other. And please try to do it in a systematic manner. If you look at your textbook, there's quite a few tools that you can use. One of them is the Wound Healing Continuum, where we look at the type of tissue that we have on the wound, starting from back to yellow to red to pink. The black wound donates to eschar, that thick eschar, which is usually brown and black, can be wet, can be dry. If you have eschar, make sure that you are doing a proper assessment, because there are instances where we do not debride, we do not remove the eschar. For example, if there is lack of circulation. Yellow wound denotes to fibrinous wounds, sloughy wounds. Again, understanding that acute wounds are different from chronic wounds. Acute slough is a normal process, will be cleared by autolysis, while chronic wound slough is a problem because it increases the burden, the bioburden on the wound. It can contain biofilm and it will not allow the wound to heal. The red wound, we're talking about the bumpy cobblestone appearance, firm granulating tissue which is not painful and does not bleed easily. If it is pale red and bleeds quite easily, that is not granulating tissue, that is actually a tissue which is showing us that there is probably an infection. Epithelialization, the pink wound, remember that the epithelium always travels from the side. One trick to check about the epithelium is gently press the edges of the wound and you see the wrinkling of the epithelial cells. But remember, even epithelial cells need to be protected and covered. Wound infection, we will talk in the next session when we are talking about the wound bed preparation. The other discussion is looking into exudate, understanding first of all, is exudate good or bad? And the answer that is depends. Depends on the color, the volume, the viscosity, and the odor. The normal exudate, which is really important to create that moist wound healing environment, is pinkish or almost transparent and very light. While if you start getting problems, the volume starts increasing, the color starts changing, it starts becoming thicker, which means that the wound is getting into problems. In the textbooks, as I said before, you have these type of tools that you can plot around the type of exudate that you have. And one important thing to remember is that when we are doing the assessment and creating a treatment plan, make sure that we are treating the cause, not just the symptoms. So if we have high exudate, we don't just tweak it up with a foam dressing. It's like having a faucet which is leaking and you put a bucket underneath it. Understand what is causing the exudate. Usually it's the infection, usually it's the slough. Remove that and the exudate starts going down again. Because the issue with exudate is that the wound can be either dry or wet. So if it's dry, usually it is because of problems in the system of the patient, things like ischemia, for example. But it could also be that the patient has put high levels of exudate, which is either due of the wound itself, for example, infection, or else because of the type of wound you have. For example, if we look at venous leg ulcers, they are usually quite wet. Remember that exudate is not just troublesome for the wound, but it is a very big issue in stressing our patients. Think about also assessing the odor and documenting the odor, because odor is one of the indicators that a wound is infected. And remember always that very important health-related quality of life. Make sure that in your assessment you are talking also about pain and making sure that we are talking about what type of pain, what makes it better, what makes it worse. When you're doing your assessment, make sure that you include the environmental assessment of your patients as well. Where are they living? What type of care do they have? Do they have access to healthcare? Can they go into their own home? For example, if they are now in a wheelchair, do they have wheelchair access? Do they have support services, for example, for their nutrition? What is their status of psychosocial being? Do they have, for example, dementia? So also important that when we do the assessment, it is that holistic assessment, because the wound environment is not just the wound. The wound environment is not just the wound and the peri-wound. remember what we started talking about first, that you have to treat the whole patient rather than the hole in the patient.